Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flamm, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome back to the Seasoned Sonographer. I'm Lynn Flamm, registered diagnostic medical sonographer, and today's episode is extra special because we're not just talking about ultrasound, we're talking about ultrasound through time. What did OBGYN imaging look like decades ago? What changed? And how did standards from AIUM shape what we do today? I'm honored to welcome Dr. Don Bishop, an OBGYN physician with over 30 years in the field. Across 3 decades of practice, Dr. Bishop has witnessed the full transformation of OBGYN ultrasound, from early limited imaging to today's advanced exams, shaped by detailed standards and documentation requirements. He brings a unique perspective on how clinical care, technology, and professional expectations have evolved over time, especially through the growing specificity of AIUM standards and the shifting of influence of ACOG recommendations in prenatal imaging. In addition to decades of patient care, Dr. Bishop served as a medical director in the hospital setting, supporting quality initiatives, credentialing, clinical operations, and patient safety. Today, Dr. Bishop continues practicing in a group practice, offering veteran-level clinical judgment, strong collaboration with imaging teams, and a deep commitment to patient-centered care and mentorship. Welcome to the Seasoned Sonographer, Dr. Bishop.
Thank you.
So let's start by going back 30, 31 years. Take us back to when you started OBGYN and what ultrasound looked like back then and what ultrasound offered as far as diagnostic information.
When I arrived in Carbondale, I was surprised to discover that the hospital had almost no OB ultrasound capacity. And even at the clinic in our office, it was not a big focus. And nobody really seemed to know a lot about ultrasound. And I had never intended to make ultrasound a focus. In residency, as residents, we all had to scan. When patients came in the middle of the night, we did bedside ultrasounds on everybody. But I was never as good at getting images and just the hands-on holding that transducer and getting those subtle little changes to get the image that you needed. It was never one of my gifts, and so I had never planned to do much with ultrasound. I just figured I would send them to whoever, but there was no whoever, and you and I became whoever.
Right.
In order to get it done right, I ended up needing to learn more. And so I think part of it, if somebody else could get the images, I could recognize the images.
Right.
I just couldn't. I couldn't hold the transducer.
And so you had to rely more on your clinical skills as opposed to ultrasound so much because the resource just wasn't there, or it was just so new and
the equipment. I mean, it was just, It was a whole different. We had an Ultramark 4, which was, our images were just so pixelated that, you could just see the little square boxes trying to form a curved line. Penetration was not nearly as good. The evolution of ultrasound equipment has been a major factor in the improvement in quality that we have seen over the last 3 years.
Better penetration, better optimization techniques, harmonics.
Harmonics was a big,
the high frequency transvaginal probes add so much, and those now have Doppler capabilities. And I remember when I was a student, I was in St. Louis, and they got their first transvaginal ultrasound probe that had Doppler on it, and they were trying it out. So,
Yeah.
yeah, it's come a long way.
It,
The equipment and the capabilities of optimizing those images.
in my opinion, the biggest change, the thing that pushed the quality of ultrasound forward was AIUM and our efforts to get certified, and that whole process of certification was a good thing,
Yeah.
and it
It made you better.
it made us much
Yeah.
better, and it also it it just broke the problem down into all its little component pieces, and we you, it gave a standard picture of what an ultrasound should look like, whether regardless of where it was done. And if you followed that template, you got good results.
Hmm.
It really improved results. Standardization was, and it occurred at a time that image quality was improving greatly anyway, but just because the machines were getting more and more better pictures, the
Right.
more pixels per square inch, and just better quality images, crisper, clearer.
Right. And that was in the 1990s.
That was in the 1990s.
And then it seems like there was another big AIUM push in the 2000s that really brought those standards back up and those guidelines to the forefront, and more offices are getting accredited and creating that consistency across their departments and their sonographers. So,
I think that for a long time there was not a there were no real requirements to be AIUM certified. Carolyn Lee came to Carbondale and presented um, a case series of cardiac malformations that had been diagnosed prenatally. And I think there were 13 malformations, and 12 of them were diagnosed by you in our office. The difference was that we did a standard four-chamber heart, and we got every bit. We had 11 things that we wanted on that four-chamber heart. We did outflow tracks on everybody, and just getting the four-chamber and outflow tracks, you pick up a whole lot more. There were tragic outcomes that we averted simply by following a process.
right. And you and I both remember when the four chamber heart view for the standard second trimester scan was all you needed. And then they added the left ventricular outflow tract and the right ventricular outflow tract. And now they've added the three vessel view and the three vessel trachea view, which are AIUM required per their guidelines. And it's required for the 76805. And so, yeah, sonographers need to definitely be adding that to their heart screening.
And we're seeing prenatal diagnosis as the norm, where that was not the norm. We had these blue babies in the nursery, and these, trying to keep the ductus open and then get them to St. Louis. And if a baby has a kidney malformation, you got weeks to figure out what to do with it. You know, you can't hold your breath long enough to drive to St. Louis.
Right.
And some cardiac lesions, you're basically like holding your breath. So the prenatal diagnosis of heart defects is absolutely critical for delivery of good OB care. And I mean, I think we both believe Carolyn Lee absolutely was the backbone of high quality fetal cardiac imaging at the community hospital level. Because it doesn't really matter what they can do in St. Louis if the patient is in Hardin County.
So extremely rural areas. Yeah.
In rural areas, you've got to get the knowledge out, and it's things that can be done in the rural settings. These are all doable things, but you have to get that knowledge out to the community sonographers. Have to be doing the screening, and then the fine tuning. They can decide, all the community sonographer has to do is know that the four-chamber wasn't normal. A good sonographer couldn't get a four-chamber heart, and so there was something. You don't have to make the
Right.
diagnosis. You get them to St. Louis, and that changes an outcome.
Hmm.
And so I think that we saw that evolution.
Yeah, and a lot of times if you know what the normal looks like, you will pick up the abnormal. And you don't, like you said, you don't have to know exactly what it is, but you know that it's time to make the referral so that somebody can pinpoint exactly what the malformation is.
When we started, it was right around not long after we started that the Radius study was published. And the Radius study was just routine ultrasound in pregnancy. Is there a benefit? And in the Radius study, it was done at multiple centers, and it showed that it did nothing, that the anatomy screen did nothing. Um, that in the Radius study, in that entire study, there were no cardiac defects found in community hospitals in that entire study.
Is it because the equipment was so bad and the sonographers were
Probably
not,
because this
able
was
to recognize?
early. The data was collected in the early '90s. I can't. It was. I can't think of the guy's name. He was at several conferences, some that we went to together.
Mhm.
That he looked at hearts, but he was using the big machines like they had in the hospital. What was the
Oh, that was Accuson.
Accuson? Yeah,
Accuson, yeah,
he
was
was
always in the
using
hospitals.
Accuson equipment, but he could just find. He was just better at that than everybody else. But he, if we got the patients to him, he could find things. But the problem is, people are going to be screened out in the community setting, and you have to have an integrated system. Um, your centers of excellence have to be able to do their bit, but you can have the best center of excellence anywhere. And if the people whose babies have heart defects never come to the center of excellence,
That care is lost.
that care is lost.
Right.
And Carolyn Lee made a huge difference in our region.
By coming to our rural community hospital and going over cases and, yeah, expressing what
She
was
taught
caught, what needed to be
stenographers.
caught.
She taught stenographers. She broke the problem down into digestible little bits, and she taught. You
Mhm.
could tell in our practice by looking at the images who had gone to her course and who hadn't.
Mhm. Yeah,
I mean, it was just
right.
you'd get these crisp, clear four-chamber hearts with, offset of the valves and moderator band and the angle and the size and
Yeah. Yeah.
everything right there. You got one picture, and you get all these things from that one
Mhm.
picture. The the foramen ovale opening right to left, the pulmonary veins coming back into the left atrium, all that in that image. There's a lot in that. And we'd have half of our sonographers, that's what it would look like. The others would show that there were indeed four chambers. And
Yeah.
so Carolyn made a
Yeah.
huge difference.
So, speaking of rural areas, and we're in a very, very rural area, and when you're talking about the very southern tip of Illinois down,
We're an OB
where
desert.
we are in an OB desert. So with rural areas comes an increase in comorbidities, and they have them in the cities too, but the rural areas are especially affected by type 2 diabetes, obesity, chronic hypertension, and all those kind of go hand in hand. And then these women are getting pregnant and have unhealthy pregnancies. And so the guidelines have changed so much. And years ago, it's only been fairly recently that obesity is now a risk factor, and you are high risk if your BMI is greater than 30, 35. And so that triggers all kinds of extra ultrasounds and sometimes fetal echo. If you're type 2 diabetic, you need a fetal echo. And so Yeah, all that's changed so much. Looking at the amniotic fluid, um, going from the amniotic fluid volume, the AFI, to a maximum vertical pocket or a single deepest pocket. That's our providers use both, and I think the overall number is still important. So
We use both.
use both, yeah.
I I believe that, I mean, our MFM consultants are mostly about the greatest vertical pocket, but our clinicians are not.
Hmm. Hmm.
They want that AFI.
Right.
So
And same with placenta grade. That's kind of fading away in the maternal fetal medicine world. But rural community hospitals and OBGYN practices, we're still talking about placenta grades and what those placentas look like. And maybe it's not necessary, but we still do it.
we do. I think that the AIUM, by giving us a structure for how to provide excellence at the local level,
Hmm.
I think that has pushed the science of ultrasound forward in the rural community setting. And and rural communities are different from urban communities. I mean, there's pathology everywhere, but there are additional barriers. Um, when when somebody is in the inner city and they have whatever issues, one issue they don't have is that they can't get to the MFM. That's not really, it's a barrier to get them to go, but the issue is in convincing a human being to do something that they might
Right.
not automatically do. When you're trying to, you can have the complete cooperation of somebody, but if somebody lives 110 miles from the MFM office
And has limited resources.
and has a truck that's 25 years old that doesn't always run,
Right.
they can't make that truck run.
Right.
When you need twice weekly testing and the testing center is even 30 or 40 miles away, again,
It's a big deal.
that that reliable transportation is a huge barrier. Getting the testing out to the rural communities is one of the critical things, and that means getting sonography out to small hospitals that are not doing OB, but that can take care of a handful of OB patients
Hmm.
and still do it well.
And then too, Doppler has changed and it's shifted from a specialty tool to something we use every
Oh,
day.
yeah.
Color flow, color Doppler, and then the pulse wave Doppler for umbilical artery, Dopplers for growth restricted babies, and even the term intrauterine growth restriction changed over the years to fetal growth restriction. So sometimes I still catch myself saying IUGR, but it's not, it's FGR.
I've got FGR in all my notes, but I think the IUGR term is still used. That's a common thing. I mean, just by
Yeah.
definition, at least 10% of people have IUGR
Yeah. Yeah.
because it's in the
Because of
10th
those
percentile.
because of those comorbidities.
And those, I think that at the 10th percentile, automatically 1 in 10 is already going to have IUGR. But when we look at our comorbidities and substance abuse and tobacco abuse, those are culturally common things in Southern Illinois. And so we have a lot of IUGR. We have a lot of people who need Dopplers. I mean, Doppler, you can't do an anatomy screen. You need to be able to show the umbilical arteries going around the bladder,
Yes.
and you need Doppler for
Yes. And that power Doppler is what I use all the time for that and cord insertion into the placenta. That's
that. And
just
yeah, exactly.
the best pictures. What about cervix length? We used to just take a glance at it in our midline longitudinal view, and now ACOG recommends a cervix length screening mid trimester for everyone. They recommend it transabdominally with an experienced sonographer and no history of preterm labor and delivery, but vaginally if you can't get a good look or if they have a history. That's changed. That's a big one.
It's been controversial, I think. We do it on all we almost always do it transvaginally. That's probably partly because I whine if we don't. There are insurances that won't pay the additional whatever that is, but we do unless the patient refuses, we do it vaginally. I feel like vaginal imaging of the cervix is just better. Um, Distance to the placenta is more reliable. Um,
Right.
and cervical length, I mean, there's a standard way to do, again, just these standard ways to do things.
Mhm.
If we all do them the same way, even if it's not the best way, we'll eventually figure that out if we all do it the same. And so,
Right, the technique for a transvaginal cervix length, is a certain way, based on those guidelines. Insert the probe, pull back, take the pressure off the
yeah,
cervix. The anterior and posterior lips should be about the same size. When you measure, it's the straight line method from the internal os to the external os, and yeah, that's the way it should be done.
yeah. And cervical length, there are, if the cervix is shorter than 2.5 centimeters, there are things that we do. It changes the care.
Right.
And not everybody who has a short cervix will deliver early, and not everybody who is treated for short cervix will respond to the treatment. But some of the people who are treated will respond, and some of the people who are discovered will be treated. And if we screen everybody, then we will improve. There will be a subtle improvement in outcome.
So I'm thinking back to when we worked together and our communication together was so great. And if I had a question about a scan, I would ask you, and a lot of times you would come in and review images with me. And early in my career, when I worked at a hospital setting, the radiologist was always there, physically there, and he would review my images or she would review my images and say, I think I want you to get a better view of the whatever it was. And then let me look at it. So I would go back into the exam room. I would get a better four chamber heart view or a better, more accurate abdomen measurement. And I would go back and they would look at it and say, yes, this is good. The patient can go, or no, try again, be better, work harder. And that was a great way of learning. And now I feel like without that direct feedback from either your in-house physician that might be too busy, or you're scanning and they're, you know, not in the office, but the mid-level or APP practitioner is, I feel like the feedback is not there, and there are not I don't have a sonographer in the office at the same time I'm there, and that's fine because I'm experienced. But somebody who's not experienced, not to get that feedback daily on every scan is just a more challenging learning environment and more challenging setting in order to make diagnostic.
The radiology model is better than the OB office model most of the time. I mean, in most offices, it is. It's hard for the sonographer and sonologist or
Mhm.
obstetrician,
Mhm.
whatever you want to call that person. It's harder for them to get together, and it's part of the culture of radiology to
Yeah.
for the radiologist to be present, looking at the images, and say, "Hey, I don't like
Mhm.
these. Let's try them again." And it's not a slam at anybody's. Um,
It's just the way it's
it's
evolved.
just part of the culture.
Right.
It's please do
Some
that.
things changed for the good, and some things
In
changed
the
for the.
office setting, that's we get some. I mean, and depending on the office and depending on who's there, um, some some of the obstetricians will call some images and say, these aren't quite good enough. Even, but that's not as built in as it is in the radiology setting. Um, Still, the quality of images has just it has moved forward.
Right.
I think
And that allows sonographers to be better because they can
Yeah.
see. They can see better. And if you can see those landmarks and, image better, then you're going to be better at diagnosing. You practiced through several eras and you're currently in a group practice. What has changed most in daily OBGYN life today versus early years?
In the early years, I think the basic model was that an obstetrician had a patient and a patient had an obstetrician. And generally, women had a one-on-one with with a specialist who was going to deliver their baby. Or sometimes there were call arrangements, and not everybody got their person to do. But there was a sense of I am Dr. Bishop's patient,
Right.
and that has completely been ironed out of the interface.
You get whoever's on call.
You get whoever's on call. You get your next appointment with whoever has the relationship between the obstetrician and the patients is not nearly as warm or close as it was 30 years ago,
Right.
even 20 years ago.
I'm thinking back to your private practice and those relationships that just ran so deep, and even all the way back to, your childhood, where you grew up in a very rural area setting, and all those family members and friends of friends and my cousins, whatever, would come to see you because they had that connection and felt that connection with you. And then you delivered their daughter and their daughter. And
We would get, I mean, and some doctors were more, um, Doug Gates and I both. That was very foundational in our
Mhm.
practice. But it's almost like that's bad. We don't even, everybody goes to a provider. Most people don't know the difference between a midwife and a doctor in terms of their care.
Mhm.
And midwives. I have been an advocate for midwifery. Um, I had the very first midwifery practice in Southern Illinois. I was very much a part of that, and I've I've worked with midwives my whole career. But there's a difference, and to ignore that difference and to pretend that there is, which is kind of the way that when you let AI do the appointments, um, then you don't. There's it's just a provider, and we're all providers.
Yeah.
But it takes a lot of the personal contact, and I don't know that it's all good.
Yeah. Speaking of AI, so ultrasound machines now have AI capabilities on them, and they're able to take measurements and eventually recognize abnormalities through sweeps and things like that. So, how do you think that's going to affect ultrasound in the future?
I fear that it's going to impair the skills of the typical sonographer, and I don't think it's going to improve clinical outcomes because there's a there's a human connection that's part of when the sonographer shows the mother the baby, and there's a human connection when the mother talks to the obstetrician, and these these pixels are one part of what we get, but the pixels are not the entirety of the discipline of obstetrical ultrasound. And AI cannot, in my opinion, give moms the reassurance that an experienced sonographer can, and the sense of well being and the sense of being cared for in the same way that human contact can.
Right.
And if we dilute the skills of sonographers by replacing them with a less expensive AI substitute, we're going to dilute the quality of care.
You'll lose that connection. And you're talking like if AI is completely doing the scan as a robot type of thing. Right. So, well, after 30 years, what are you most proud of, and what life lesson do you want younger providers and sonographers to carry forward?
My favorite time in my career was during the solo practice and that small group of people.
That is something to be proud of. Yes.
We were committed to our patients in a way that I don't think it can be duplicated. But what I would say to young people is there are great opportunities to connect with other people and to do something worthwhile to make your life feel like it counted for something. And so I still think the interaction between sonographer and physician, if you create a setting where you're really working together, the MFMs often have that kind of setting. If you can work in that kind of setting, there's rewards in that, and it may not all be dollars and cents rewards, but there's probably more to life.
Making those connections, treating people how you would want to be treated. And my favorite quote by Maya Angelou is, "It's not what you said, it's not what you did, it's how you made them feel." People will remember how you made them feel. And at the end of the day, you can make the diagnosis, but that human connection is transcends all years of practice.
I totally agree with that.
Yeah. Yeah. Well, thank you for coming on. I really appreciate it. Do you have anything else you want to offer up or say? We didn't talk about when you were a medical director at the hospital, the OB director. Anything you want to say about that?
I think that local leadership is an important thing. I think that excellence, everybody's idea of excellence is not the same. And as healthcare has become so much more of a business and so much more of an entity that is dominated by administrative personnel, where clinicians, sonographers, nurses make up a much smaller piece of the healthcare pie. Um, I think I think that excellence is getting shifted away from how we make people feel as we
It's more financial driven, it's encounter driven, it's hurry up. You have to meet this number of encounters in order to reach your bonus, which is, sometimes like a carrot dangling from a string way out in front of you, and you run and run and run and never catch it.
That's exactly right. And that's I feel like there is so much, the power structure has changed and clinical decisions are in the hands of non medical personnel so much of the time. And I don't think that's, and so then we have trouble agreeing on what excellence is. To me, my whole career as a physician leader, my whole concept of excellence was OB safety. If if our patients are safe and we're delivering healthy babies, then we're doing a good job. And everything that dilutes safety is something that we need to eliminate, whether it's cost effective or not, whether it's in line with the mission or the vision of some administrator or not. If we compromise safety, we're making mistakes. And that we it's it's like, to me, it's an intrinsic value. What women want is a healthy baby. They want the experience. They want the excellent center. They want this. They want that. When you cut through, at the end of the day, they want to take a baby home the next day that's healthy and that's not going to ride the short bus to school.
We didn't talk about 3D and 4D imaging. That's new. 3D and 4D imaging, we saw that come about within the last 30 years and how it's improved.
Oh, I know, but it started off as just entertainment.
Right.
But
quickly became diagnostic.
Oh, yeah. I mean, it's volumes is like volumes is big business in, like, I mean, everything. It's just like putting a cursor on and doing a measurement. Now we need to know the volume of the whatever.
And like I said earlier, whenever I do a transvaginal GYN, I do 3D on those endometrium all the time.
We're not doing that, but I think we should be.
Looking not only for IUDs, but fibroids, polyps, things like that.
We could do a lot more with fibroids with 3D.
It just gives you a better view on how deep they run into that endometrium and what exactly is causing maybe that abnormal uterine bleeding. So, okay. Thank you.
Okay.
Thank you so much for joining me for this episode of the Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to the Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.